Good afternoon, everyone. Thanks for joining us for Advanced Echo teaching today. The great news is Vishal Gupta, one of the staff specialists here at Nepean Hospital, is going to be giving us a talk on mitral valve prolapse. Thank you very much. It's a challenging topic. And then we'll have a bit of a chat about the mitral valve in general at the end.
Thanks, Sam. Hi guys, good afternoon. So, mitral valve prolapse, I think it's a very tricky topic, and but I think if we have good understanding of mitral valve anatomy, then I think it's not a difficult topic. So in this, in this talk, I'm going to spend a little bit of time on the mitral valve anatomy, and then we'll talk about mitral valve prolapse as such. So mitral valve, there are 5 parts of that. So to start with, you can see mitral annulus, then mitral leaflet, anterior and posterior, then a couple of commissure, Chordae Tendinae, then Papillary muscle. We'll talk about one by one. So to start with mitral annulus, so mitral annulus, you can see it's a fibroelastic ring which encircles the valve orifice. It's a saddle shape, and interestingly, its shape is elliptical in systole and it becomes circular in the diastole. And you can see on anteriorly it has got aortic valve, and on the lateral side it's got left atrial appendage. And mitral leaflet, so 2 leaflets, you can see the anterior and the posterior. So anterior is larger and thicker, which covers the 1/3 of the ring, and it has got strong anatomical support and 3 scallops, so A1, A2, A3. Normally A1 is the lateral, A3 is the medial, and the posterior leaflet, which is thinner and more flexible, which covers the 2/3 of the ring. It has got weak anatomical support and the same 3 scallops, P1, P2, P3. P1 is the lateral, P3 is the medial. And because the posterior leaflet, it has got weak anatomical support, so that's why the posterior valve prolapse is more common as compared to anterior. And commissure, a couple of commissures, so anterior lateral and posterior medial. So these are, basically specific sites where leaflet inserts with a mitral annulus. And then the Chordae Tendinae, so fibrous strings which attaches to the leaflets with the papillary muscles, couple of centimeter long and 1 to 2 millimeter thick. So Chordae Tendinae, 3 types, so primary, secondary, and tertiary. So the primary Chordae Tendinae attaches at the leaflet tips. So it helps in forming this coaptation line. So any rupture of the primary Chordae Tendinae, it can lead to significant MR. And the secondary Chordae Tendinae, which attaches at the mid body of the leaflet, a rupture of this, you can have, may or may not, you can have mitral regurg. Whereas the tertiary, it's mainly function as a structural support and it touches the base of the leaflet. Then papillary muscle, so anterior lateral and posterior medial. So it between lower 1/3 and middle 1/3 of the ventricle where it sits. So that's where I'm going to spend a little bit of time. So it's for this topic, it's very, very important to understand the anatomy of the mitral valve. So that's how we see mitral valve. So you can see the top one, that's how surgeons they look at, and that's how we look at the mitral valve. The only difference is medial is lateral and lateral is medial for the surgeons. So I'm going to spend more time on the sonographic view. They can see that, so how I remember that which one is anterior, which one is the posterior. So it's not necessary that you will see the aortic valve all the time. So as you know, that right ventricle is the anterior structure. So I look for right ventricle. So wherever there's a right ventricle, or if you can see the aortic valve, that would be great. So that's your anterior mitral valve leaflet, and the other one is the posterior. So that's how I differentiate between anterior and posterior. And between lateral and medial, which one, like A1, which one is A3, wherever there's a left atrial appendage, so that's your lateral side, so that would be your A1. Other medial side would be your A3 or P3. So anterior, posterior, lateral, and medial. So we'll talk about transthoracic anatomy first, then we'll talk about the transesophageal. So to understand or to remember myself, so I always start with short axis, because then I can orient myself better if I start with short axis. But everyone has different ways of remembering things. So with a short axis, this is the mitral valve level, and this is the fat muscle level. So it's the same which we just saw that this is a lateral, this is a medial. So lateral side is A1, and medial side is A3, anterior is aortic valve. And easy, right? So that's how we remember, and you can see this is how we see in the short axis view. So as I just mentioned that I look for the right ventricle. So this is the right ventricle, and that's why it has to be anterior. And other one is posterior. And because on the right side of the image, it's the lateral side, so that's why A1. So easy. If you remember that, when we need to change from short axis or long axis, we just move the probe by 90 degrees. So that's how we need to do it here as well. So just a 90-degree cross section. So it would cross between A2 and P2. So this is your parasternal long axis. So this is your aortic valve. This is your right ventricle. So that's why it has to be anterior, because aortic valve is anterior to the anterior leaflet. This one is posterior because and it's cutting down at 90 degrees. So that's why, this is A2, this is P2. So short axis 90 degrees. Then apical four chamber. So in the apical four chamber, so at parasternal long axis, we, cut it at 90 degrees. Just think that, we just need to move the probe or move the cursor by around 60 to 70 degrees. So we'll be cutting, like here in posterior P1, then in the anterior A2, A3. So this is your four chamber. This is your right ventricle. That's why it has to be anterior. This is the posterior. So that's how I remember. So posterior P1 and anterior A2, A3. So P1, A2, A3. And then the apical two chamber. So we just need to move the same cursor by 10 to 20 degrees more. So this is I have written here. So in the center is A2, so apical two chambers, so A2. So it just this is how I remind myself. So A2 is in the middle, and other P1, P3, so it's in the sequence. So P1, A2, A3. So apical two chamber is A2. So easy to remember. So just to summarize, so start with the short axis. You have got A1, A2, A3. Cut at the 90 degree, you will get A2, P2. Move the cursor around 60 to 70 degrees, you will get P1, A2, A3, and move around A2 10 to 20 degrees. So P1, A2, A3, apical two chamber is A2, which is in the middle. That's how I remember. Then move to the trans-esophageal view. So we'll come back to this image. So this is just a summary of all the views. To start with, mid-esophageal four-chamber view. So mid-esophageal four-chamber view, 0 degree or 180 degree, whatever you can say, but 0 degree normally it is at. So the way I remember is that it's the same as that of parasternal long axis view. So we are cutting in the middle, A to P2. So you would have the same leaflets. So this is your mid-esophageal four-chamber view. This is your right ventricle. So that's why this side is anterior, other side is a posterior leaflet. And it's cutting in the middle. So in the parasternal long axis, if you remember, it was A2, P2. So in the mid-esophageal four-chamber view, it's the same, A2, P2. And then mitral, commissural view. So we have moved the oblique at 60 degree here. So just to remember that mitral commissural view is the same as that of your apical two-chamber view. Apical two-chamber view. So it's the same, P1, A2, P3. So apical two chamber, A2 in the middle. So P1, A2, P3. So that's how it's cutting it here. So mid-esophageal four-chamber view, equivalent to your parasternal long axis. Commissural view, equivalent to your two-chamber view. And mid-esophageal two-chamber view. Now we have moved, this cursor at 90 degree. So, the way I remind myself in this one that it has got a little bit of posterior, but mainly the anterior. So a little bit of posterior means that it has got P3 and the whole of anterior. All of anterior means A1, A2, A3. So the whole, all the three scallops would be there. This is anterior because it is a left atrial appendage on this side. That's why this is your A1, A2, A3. So, make sure you look for your right ventricle or aortic valve or left atrial appendage. And then, sorry, how do I go back?
You can just click on this.
And so long axis view, 120-degree. And, just to remember that it's the same as that of mid-esophageal four-chamber view or parasternal long axis. Again, A to P2 is cutting in the middle. It's just, your orientation is opposite because now you've got aortic valve on this side. So that's why this is anterior, other side is posterior. So A to P2. To summarize, this is, Sam's famous hand. And so he explained me, a few months ago that how to orient yourself. Sam, you want to comment anything on that?
I just try and do it with your left hand, and then your right hand is the 0, 60, 120 degrees. So you're using your hand to orientate yourself as it's the toe probe. But your hand is beautifully held to be, as long as your left hand, it mimics what's on the screen here, and just start off parallel with yourself. And that's how you know you've got the A2, P2. So it's the anterior mitral valve leaflet is the apparent space left by your thumb and the hand. And then your posterior leaflet is the hand as you see here. And I find it really useful. You've got to imagine you're having a surgeon's view looking down on the mitral valve. You hold your hand steady as you would just holding up straight in front of your face, and then start vertical and work your way around at 0. Then you can rotate your hands clockwise for 60 degrees, 90, 120.
I find it very handy and very useful. And
very handy, nice.
Okay, now let's talk about mitral valve prolapse as such. So, mitral valve prolapse, so you can see in this image, so there's a posterior displacement. And, beyond the mitral annulus, at least 2 millimeter. And the leaflet tips should be pointing towards the apex. And they may or may not be mitral valve thickening. So these 4 points is important. So posterior displacement, more than 2 millimeter, tip pointing towards apex, and there could be mitral valve thickening. It's important to differentiate it from the flayed leaflet. The important point is that in the prolapse, so the tip is pointing towards the apex, whereas in the flayed leaflet, the tip is pointing towards the left atrium, away from the apex. So it's important to differentiate these two. And typically, flayed leaflet is associated with, ruptured Chordae Tendinae or, papillary muscle, and, one of the causes was acute and severe MR. So to classify mitral valve prolapse, so mainly, 3 types: myxomatous and MEP syndrome and secondary. So myxomatous mitral valve disease, so mainly, known as a classical primary MVP. So mainly in the middle-aged males. Could be familial, non-familial, or associated with connective tissue disorder like Marfan's, and mainly characterized by increased redundancy or increased thickening of leaflets. Whereas MEP syndrome, so also refers non-classic mitral valve prolapse, mainly in the young females, and typically they're present with this MEP syndrome with mid-systolic click, and there's a displacement more than 2 millimeter, and there's a thickening of the valve. There could be, MR present or absent. It's not necessary. And the last one is secondary mitral valve prolapse. So it's also known as functional or hemodynamic mitral valve prolapse. So in this, there's either reduction or alteration in the left ventricle cavity size or shape, and it may cause normal mitral valve leaflet to move past the mitral valve annulus during the ventricle systole. For example, in coronary disease, rheumatic heart disease, cardiomyopathy, hypovolemia, left right shunt, you can have this functional mitral valve prolapse. Clinical presentation. So MEP is one of the most common causes of isolated MR, and patient may be asymptomatic, or they can present with MEP syndrome with classical systolic non-ejection click, and all the symptoms of fatigue, palpitation, and syncope, or if your MR is severe, then the MR related symptoms. So few important echocardiographic features. I think M-mode can be quite useful in the mitral valve prolapse. So on the left side, so this is the normal. So you can see this is the diastole, this is the systole. In the diastole, this is your E wave, your A wave, and systole here, your C to D point where your mitral valve close. So both the leaflets. So this the anterior, this is the posterior. So here both leads are closing. And in the if there's a prolapse, so if there's only posterior mitral valve prolapse, you will see this sagging, again more than 2 millimeter. And if your both leaflets are collapsing, you will see both of these leaflets are, would be sagging on M mode with C and D point. So I think this M mode could be quite useful in this setting. In the B mode, so again, you will see that displacement, posterior displacement. The important point to mention is that normally we diagnose, mitral valve prolapse in the parasternal long axis. So if you're trying to diagnose it in the apical four-chamber, it's not, very well validated view. In the ACA guidelines, they have said that, don't diagnose your mitral valve prolapse in the apical four-chamber. And if you're trying to diagnose anterior, mitral valve prolapse in the four-chamber, it's not 2 millimeters, at least 1 centimeter displacement you need. Otherwise, you could, false positive, there are high chances. But on the other hand, posterior mitral valve leaflet, you can have 2 millimeter displacement in any view, including four-chamber. But mainly for the anterior mitral valve leaflet, 2 millimeter is not enough in the apical four-chamber. And the other features like thickening of the leaflets, as we mentioned, and all the hemodynamic effect of prolapse and MR, like left atrial dilatation and left ventricle volume overload pattern. And rupture of Chordae to P2 scallop is the most common because it has got very weak anatomical support, as we discussed. And the Doppler, you will have significant MR, and which is predominantly late systolic. And if it's anterior mitral valve prolapse, you will have posteriorly directed MR jet. If it's a posterior, then other way around. Okay, so that was a quick, about mitral valve prolapse. Now we're gonna go through some cases. Any takers who's gonna do the first one? First one is easy. Emma, do you wanna try? Your name was, sorry.
In alphabetical order or something.
Okay, here you go. So 52-year-old gentleman, no cardiac history, patient is presented with new onset AF, and someone ordered echo just to evaluate this atrial fibrillation.
So I can see the left atrium looks dilated. It's not a great resolution of the mitral valve, but you get the suspicion there just without colour that there's some prolapse of both leaflets, possibly more of the anterior actually. And then with colour on it, you can see that there's it's an eccentrically directed mitral regurgitant jet.
What do you suspect if it's anteriorly directed MR jet?
Yeah, then I'd expect it to be a posterior mitral valve prolapse.
I'll give you a bit better view. So what about that?
Well, that's nicer. Yeah, so I mean, it's more obvious the posterior leaflet there, but I think also the anterior. So I think it's A2 and P2 that are prolapsing there.
Which scallops we are talking about?
P2 and A2. Yeah,
so parasternal long axis, we are cutting at 90 degrees. So we are talking about A2, P2. I think what about now? So we did some measurements.
Nice.
So you can see the anterior is normal, but the posterior, the P2 segment, is a 1 centimeter displacement. So it's mainly, it's a P2.
And I think the color Doppler gives you all the clues there with the anteriorly directed eccentric jet. You've got to be thinking it's the posterior. If there was both the A2 and the P2, you could be expecting a bit more of a central looking jet because they're both going.
You can look, short axis. This one is not that clear,
But it still helps to show you anterior.
Oh yeah, that's really obvious on that one actually.
Oh, you pause it perfectly. Don't
And posterior you can do it on any view, can't you? So that would be,
posterior any view. So you can see it's very nice,
That's really nice, yeah.
So in the apical four-chamber, can you, Emma, please remind everyone what scallops we are looking at?
So we're looking at, in the apical 4, we're looking at P1, and then A1 and A2.
So, so this is your anterior, this is your posterior.
Yep.
And, if you remember, P1, A2, A3. So this is your P1,
A2, A3.
and this is your A2, A3. But, it also depends on, where you're moving the probe. If it is a bit superior or inferior, it's not necessary you will get P1. You can have P2 or, so I think, because we already know in the other views it's a P2. So it all depends on how much, probe it's a superior or inferior, then, it would change. And as you already, previously mentioned that, anteriorly directed MR. So it's pretty good view in this one.
Yeah.
Straightforward. So what's the next one?
Do you want to just cover up the top and just see who else is online if you click the arrow to the right? So Danielle is also doing her exams.
Danielle, you want to give it a try next one?
Yep, okay.
Thank you.
I'm really liking it that I'm asking other people. So instead of people asking me. So 70-year-old gentleman, history of atrial fibrillation, some SCC of the scalp, strep Milroy bacteremia, and so I did this tour. So we were asked to assess MR and query infective endocarditis.
Yeah, okay. So this is a mid-esophageal four-chamber view. On the grayscale images, so the ventricular function looks normal, the left atrium appears dilated, and on the mitral valve, the posterior leaflet, and that would be P1, I think. You can correct me if I'm wrong. There is a mobile echo density attached to the atrial, the inflow side of the valve, and that would be consistent with the vegetation. So then going to the color Doppler images. So the color box is centered over the tricuspid valve and the interatrial septum. There is a regurgitant jet there, and I'm just trying to figure out where it's coming from, because you can see it just adjacent to the septum, and I think you can also see something wrapping around the septum on the left atrial side. So I would try and take a very close look at that in other views to try to see whether there is actually a fistula formation or an interatrial communication there.
I should have made
I can't.
better, my bad.
No, but I'm saying, like, just on this one view, that would be a clue to me to try and look more closely at exactly where that jet is coming from.
And Daniel, can you just remind everyone that, what scallops we are looking at?
Yeah, I tried to slide across that just quietly. The one to the right side of the screen is the posterior leaflet, and the one to the left side of the screen is the anterior leaflet. And I think is it P1, A2, P3?
So, that transfacial, esophageal four-chamber view, just, remember that it's equivalent to parasternal long axis. So it's cutting in the middle. So it's,
Oh, okay, so it's A2, P2.
Sorry, Sam, you were saying something.
So just, if you've got an obvious defect that's there on the 2D, that can also point you to the idea that there's going to be some significant regurgitation. So I guess I appreciated what you were saying, Danielle, saying that you wanted other views. But don't forget, you've got this significant abnormality that's sitting there on the posterior valve.
Yeah.
It looks like, you know, sorry, I forgot the bug. Was it staph?
Strep
Miller, right? So it's quite an aggressive bug. And if you're then seeing this colored Doppler, you've got to be thinking with the big 2D abnormalities that you'd be having big, horrific color Doppler abnormalities as well. Sorry, excuse me.
Yeah.
And, you know,
Yeah,
you just,
but Michelle, we can't see that previous view, can we?
sorry, what?
We can't see the actual problem.
No, we can. It's just that, you know, I've given you the magnified version now. So in the same view, with
Yeah, but
magnified
it's a
now.
better color box.
So,
Yeah.
Michelle, the mid-esophageal fourth chamber, won't you have the same plane as the apical fourth chamber?
No. It's, you know, how you, because don't think the fourth chamber versus fourth chamber, because we are just concentrating on the mitral valve, because the, you know, how you cut the mitral valve, it changes.
To be equivalent to the deep transgastric, the deep gastric,
The short axis here.
but not the mid-esophageal.
Yes, Daniel, sorry. You can, yeah, so it's the same patient, therefore, you know, a few more views.
Honestly, I don't have a great frame rate on the color at this end, but I'm guessing that that's showing severe mitral regurgitation.
Yeah. So, you know, it's very significant, and really I'll try to follow it.
You can give her the remote control. And she can
Yeah.
So, yeah.
Yeah, so that's a good example of it there, and it looks like it's severe because it's got a wide vena contractor, which I would say is likely to be greater than 0.7 centimeters, and it looks like there is also flow convergence associated with it.
And I think in this, you know, magnified view, you can see, you know, your posterior displacement a bit better.
Mm-hmm.
And so a few other views.
So, yeah, on the mid-esophageal, this is a 2-chamber.
Yeah.
The
you might
vegetation is evident again, and it actually, I'm having a bit of trouble just exactly defining what's going on with the valve and which part is the vegetation, whether it's overriding of the valve leaflets and a failure of coaptation, or whether that part is actually the vegetation. I'm not sure.
Yeah, initially when, you know, it was me and Arvind, we did this one, and when I was doing this, so we were, you know, concerned whether it's the vegetation or it's the ruptured chordae or something which we are looking at. But because patient had positive blood culture, and this looks like vegetation with independent motion, so that's why we thought it's more of vegetation than any ruptured chordae or anything. So, you know, 90-degree, you know, so if you remember, so it's a little bit of posterior, more of anterior, and this is your, you know, the right heart, so it has to be anterior. On the left side of the image, it's posterior. So it's P3, and on the anterior side, it's A1, A2, A3. In this magnified view, if you, I'll show you a better view. You can see, you know, all these leaflets, 3 scallops you can see on this one. So I thought it was pretty nice view. So
Yeah, that's nice.
A1, A2, A3. So you got all 3. So, and this is the posterior. So you can see all the 3, you know, scallops very nicely on this one. And the last one.
So this is the long axis view. Again, the mobile echo density is apparent and appears to be associated with the posterior leaflet.
You know, I'm going to ask that. So, sorry, which scallops?
Yeah. No, I'd be guessing. I don't know.
So just, you know, esophageal 4-chamber is equal to your long axis view. So again, cutting in the, you know, center, so A to P2.
Okay. So the long axis on toe is the same as the long axis on TTE, A2P2.
Yes.
Is that right?
Yeah.
Okay, but the 4-chamber is not the same.
No, the 4-chamber is different. So,
Okay.
it's a little bit of posterior, more of anterior. So only 4-chamber is a bit weird to remember. Other views are, pretty straightforward to remember. You can see it's almost your parasternal long axis, of your transthoracic echo. And that's why, because you have got this aortic valve, so that's the anterior, other side is the posterior. So, and it's the P2 scallop, prolapse. Very good. Thanks, Daniel. Who's the next one?
Jamal, are you there? Jamal, it's nice for you to join us. Can you hear us, Jamal?
Yes, I've just unmuted myself. I've thrown my children to my wife for a short period, so I have a short period of hopefully quiet.
Are we able to ask you a quick case? Is that all right?
Yeah, sure. I mean, I made a bit of time today because this is a subject that is close to my
Very close
interest.
to her. And Jamal, am I right in saying that you're officially now signed up with the DDU? We're looking
Yes.
to next year. Is that right?
Yes, that's correct. Yes.
Amazing. Well, Jamal, welcome. It's really great of you to join us. Thanks very much.
Then
Thank you.
In that case, hi Jamal. So this is a great case to discuss. So I steal this case from Sam's library. So I think it's Sam's echo, this one. So 65-year-old lady, she presented with non-STEMI and then suddenly acute severe MR. She was going for angiogram, then had sudden hypertension. You remember this?
I think this was the first week of our new Echo Fellows in 2018, and I think they thought that we had cases like this every single day of the week. But it was great to sort of start the year off like this.
So I guess from the history, you'd be immediately concerned that she's ruptured a pap muscle. And if she's going to rupture a pap muscle with a non-STEMI and have severe acute MR, it's going to be the posterior pap muscle, the posterior medial lateral, because it's got one blood supply, not two. So given this clinical history, I'd be concerned that she's ruptured a posterior lateral pap muscle and has got acute MR. And so this is a parasternal long axis view. And there is definitely some abnormalities of the mitral valve. There's something there in the cavity, the mid cavity of the left ventricle, which is concerning for, as I was saying, just a ruptured pap muscle. So on the left screen, in the mid cavity, obviously you can't see, but just then and then you can see something in the mid cavity which is far too large and far too mobile. So that's immediately concerning, even the absence of Doppler. On the right-hand side, you've got color Doppler. And you can't see anything anymore because the frame rate's diminished in the mid cavity, but there is a lot of color, which is kind of eccentric, directed towards the posterior leaflet. So these are all pointing towards kind of severe acute MR.
And Jamal, do you want to remind us again about the scallops?
So I'm always a little wary about this, but I guess the teaching that you'd have is if this is long axis, it's A2P2.
Yeah, fantastic. Thank you.
And so this is kind of on the left there, you have like so again, you've got on the left there, that's a short axis of the base. So the base of the left ventricle. And again, I think there's an abnormality there at 9 o'clock on the short axis. So I think you can see something coming in and out, which is, I don't know for sure, but I would say that's concerning. And on the right-hand screen, I've got more of a fish mouth appearance, which is kind of going straight for the orifice of the mitral valve. I'm just trying to see, I'm not seeing, again, at kind of 10 or 11 o'clock, I'm not seeing anything else on the right, but the left is concerning for that echo density, which is overly mobile, which could be a free papillary muscle.
And just give me regional wall motion abnormality, Jamal, because you said that we've got a single blood supply, and that's where the pap muscle might go. So don't forget to tell me about the regional wall.
So overall, given this is acute, the function, the global LV function looks good. I would say so. It's maintained with a normal EF, but kind of definitely there is some hypokinesis in the inferior distribution.
Very nice.
Thank you. And
there we go. So on the left-hand side there, we have an apical 4, and this confirms with again, in the mid-cavity there's again, that mobile echo density that simply should not be there. Given the clinical history, again, this remains concerning for a free rupture of a posterior papillary muscle, and that's definitely concerning on the left screen there. The right, again, with color flow Doppler of the apical 4, has that kind of very aggressive with a Nyquist, which is perfectly acceptable at 58. You've got a kind of eccentric coanda effect, MR jet into the left atrium. I'm just trying to, so again, that's kind of more posteriorly directed.
And Jamal, explain that first, because there's some of us, again, just starting out. So I've read the guidelines, and they say I need to have 60% of color Doppler filling the left atrium for it to be severe. You call this, I think you said it was significant or something like that. Talk again about the coanda effect. What do you mean by that?
Well, I guess it's just a wall-hugging jet. So although I guess we're all it's the easiest and the first thing that many and most, and even of those of us who have experienced it, do, which is kind of assess regurgitant jet severity on the basis of color flow Doppler. It's almost always the least sensitive. So I think we're all very cautious about using color flow Doppler to assess severity of regurgitant lesions, especially given the issues with loading conditions and technical settings. I mean, I don't know what this lady's blood pressure is. I don't know what her filling status is. She's definitely not at rest. So there's a lot of concerns about using color, but when you have these large eccentric jets that are very wall hugging and almost curl all the way around the atria, that signifies a large amount of kind of kinetic energy behind them. Which I guess kind of favors more severe regurgitation, even the absence of color jets that take up the prescribed amount of left atrial volume.
Very nice.
Very nice. And sorry, the last thing, Jamal, do you want to remind us about the scallops? Because that's what I'm asking everyone now. I'm loving it. So.
Okay, so I will say that I'll pass the caveat, the transthoracic is not usually what I do. But so if this is an apical 4, I guess it would be A2, A3 over on the left and P1 on the right of the screen.
Yep. And yeah, perfect. And the last, this is apical 2 chamber.
Yes. P2, P1, P1, A2, A3.
So same patient, Jamal, apical.
Yeah. The interesting thing about this is that, anyway, so the finding remains consistent, but again, now that we've got a number of views across a number of fields, you'd be far more confident that that's not an artifact or something. Definitely concerning again for free rupture. So if that's a 2-chamber view, again, I'm not certain, but from right of screen on that first image, would that be P1, A2, P3?
Yeah.
Yeah, okay. And again, this is probably a better, on the right of screen, that's probably a better example of just the kind of eccentricity and the coanda effect, where it kind of goes in some loops. You could probably stop it, but you can almost envisage it hitting the wall and circling almost 180 degree, almost all the way around the left atrium. So there's an enormous amount of force behind that. And that, I mean, I would think that's probably consistent with the clinical history of knocking off one of her pap muscles from an inferior STEMI, non-STEMI.
Any comment about regional wall in this 2-chamber?
Upside down from what I usually do. Let's have a look. Given everything, I'd expect, where are we now? I'm gonna have to look at it upside down. I'm gonna have to get better at that, but maybe the inferior wall, is that to the right of screen on the left image?
So this is your inferior, this is your anterior.
Okay. Well, I mean, I'm not seeing a whole lot of the anterior, but I would expect the inferior, given everything else, to be the one that is kind of not normal function, be it kind of hypo or dyskinetic.
Yeah. Very good.
Yeah.
Perfect. Well, thank you. And
Very nicely done.
just this comment which you already mentioned about the blood supply of the pap muscles, because the anterior lateral, it has got dual blood supply, from LAD and left circ, and whereas in a posterior medial, is supplied by the posterior descending artery, which is the branch of most of the times from the RCA, but could be from the left circumflex. So it has got single blood supply, so that's why it's more prone to have rupture as compared to anterolateral in terms of non-STEMI or STEMI or ischemia. So pretty good. And this is my last case. Oh yeah, sorry, nothing.
The rest of us have done their exams. They're a year or so away.
So 40-year-old lady, presented with APO, so for assessment of MR.
Okay, so this mid-esophageal, transesophageal, mid-esophageal 0 degrees, showing on the left-hand side, showing prolapse of the posterior mitral valve leaflet, more likely P2 in this, and showing torrential mitral regurg on the color Doppler flow, which is posteriorly directed eccentric jet, although it's huge. It's quite
Posterior or anterior?
anterior from here,
Because this is your anterior, this is your
Yes.
posterior, so anteriorly directed.
The question whether it's flail or it is a prolapse. So it looks more of prolapse at the P2 level with a zoom view.
Yeah, so it's the same view, but a little bit off axis, 20 degree. Next view.
So this at the 60 degrees, probably this is more of
Commercial.
commercial view. And this again confirming the same prolapse at the same level, P2 scallop.
And the right side of the image.
Right side of the image, it's again a zoom view across the same one. The anterior looks okay.
Only difference is it's 90 degree now. So
Yeah.
it's,
So it's just more demonstration of the same segment.
And I guess it could be A2.
Yeah.
Yep.
Yeah, and that's going to be depending on where you're fanning through it. So it's A2 or P2, but you know it's P2 because you've seen the first one. Very nice. Yeah.
And this is so this at the 120 degrees. So what would be towards the aortic valve would be the anterior.
Okay.
So the anterior looks completely okay. The posterior again is demonstrating the same. Here it will be P2 again demonstrated. And this was the zoomed view on the left side, and this is an unzoomed view at nearly at 140 degrees, and again demonstrating the same, and with poor coaptation of the mitral valve, which would be the regurgitant area.
pretty good. That's perfect. It's just that you're just trying to demonstrate that here that off-axis imaging is very, very important. So you need to fan through, so 0 degree, 20, 60, 90, 120, 140. So it's just to fan through, the whole mitral valve structure, just to, be 100% sure what scallop we are dealing with.
And my one comment again is about regional wall. If we're talking about flail or prolapse in someone with APO,
So
we've got to be talking about the ischemic coronary artery territories. Have we got a case like Jamal's one just now, or is there something else?
Yeah,
going
so
on?
global index function is completely normal, no regional.
Can I just ask a question? On the left-hand image, does that actually demonstrate that the leaflets are flail? Because it looks like sometimes the leaflet tip is actually pointing back into the atrium.
Great comment.
Yeah, so yes, and because the thing is, it's the difference between prolapse and flail we were just talking about. So the only thing is, to remind ourselves that if it's pointing towards the apex, then it's a prolapse. If it's pointing towards the left atrium, then it's a flail, right? So in this, looks like it's more prolapse to me. So I'm not sure what your comments are.
Flail.
On this, yes,
Yeah.
I'm on the right side.
Yeah.
On the Zoom.
The right-hand image looks completely like it's prolapse, but the left-hand image, I think, just in that little bit, there's just a point at which it looks like it's going backwards. Yeah, there.
Here it is. And that's why it's important to fan through and to see it in multiple views to decide what we are dealing with. So
We want to cover the mitral population, related left atrium.
Yeah. So just to summarize, I think it is a tricky topic, but if we have good understanding of mitral valve anatomy, then I think it's not that difficult topic. And so toe is very important. As Senator Jamal mentioned, that we will always need to do toe to make sure that what scallops we are dealing with, and multiple areas of effort. The choice in terms of treatment. Thank you. Any questions for me?
Yeah, I just have a question. So my practice is uniformly cardiac anesthesia, and I noted that you have some toes there, some toe images. I find this with the cardiologists as well when we kind of hang out with them. Do you do much 3D echo? Your probes look like they must be. I would imagine they'd be capable. But I would say in my workflow, the first assessment of mitral regurgitation or mitral valve abnormality is some form of live 3D imaging.
Yeah.
And there's an
in answer to your question is yes, we do have the 3D toe probe in the cardiology lab, but I think for the DDU side of things and for advanced echo education, the argument is that you should be able to get it on 2D without 3D. So I think it's the summary is that learning it from 2D is really important to then move on to 3D, because we should be able to do both. I often find that you can't, the 3D shouldn't add too much more to what you get on 2D, which is why I guess we focus mainly on the 2D for some of the teaching.
Yep, that's understandable.
Yeah. Thank you, guys. Thanks, Sam.
Oh no, that's unless there are any other questions, Michelle.
One question. That last statement there, where you've got mitral valve repair is the preferred treatment for symptomatic prolapse with flower leaflet.
Yep.
Prolapse versus flower, doesn't make sense.
So sometimes you can have both together. It's not necessary.
Last case, maybe.
Yeah. So you can have both. It's not necessary that both are isolated things. It's possible you can have both together.
So is the leaflet tip indeterminate then?
These are questions that have been and are loved to be asked, I guess, in the DDU exams, mainly because if you can understand this, it can kind of indicate that you understand echo. I think if you can answer these questions, it's a really good indication that you know your stuff. So worth having a think about, maybe looking through this presentation again. To Vishal, I think it was an amazing talk. Thank you very, very much.
Yeah, great. Absolutely. Yeah. Thank you.
Thanks, guys. Well, listen, I'll stop recording and we'll just have a chat about the exam if you're up for it. Just hang on a second.
Thanks, Vishal.